Hi, this is Brian Kim. I want to share with you this case. This is actually a really challenging case. This is a case of Cataracta Nigra. I do a lot of dense cataracts in northwest Georgia in this area, hypermature cataracts into tumescent lenses. But this is the rare Cataracta Nigra that I've seen. I've seen more of these on my mission trips, but not as common on stateside. And so when I tried to handle this case, you'll see how I failed doing the Phaco. This led to posterior capsule rupture, vitreous loss, and I was about to lose the lenses until I started to quickly pivot, maneuver, and adjust my expectations in that moment, convert to a different technique. Looking back, and part of this video is really to stop, look at what I did well, look at what I should have done differently, and hopefully do better for the next case. Because, if I have one Cataracta Nigra, I might have another one in the future. And it's very important for us to learn from our cases. And that's the other part of this video that I want to share. And that is why I record all my cases, because every case is a learning case, especially in this case of Cataracta Nigra, failed Phaco, posterior capsule rupture, lens pieces descending in the vitreous space. What should I do in that moment? So you can see here, this is the eye, this is a cataract. Looking at the eye, it might not look that impressive, but as you can tell, there's no red reflex, and it is a very shiny black cataract. I use my paracentesis incision first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine. And then this is some intracameral air. And I'm going to go ahead and put some trypan blue in. Of course, trypan blue is needed in these cases because there's no red reflex. And because there's a high risk of posterior capsule rupture and complications or anterior capsule tear, it makes sense to go ahead and stain the anterior capsule in this situation. Go ahead and push the trypan and air bubble out with dispersive viscoelastic. You can see how black this cataract is. Again, probably the densest cataract stateside I've done thus far in my career. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. And these are the sharp tip Moria microforceps. I go ahead and puncture the center. You can tell that the bag is very thin. You can see as I'm puncturing the capsule, there's some stria as I push down. You can tell that there's some zonular laxity as well. Not a terrible amount, but enough to get your attention. So go ahead and puncture. And what's interesting is even though I put a lot of trypan blue, I'm not getting very much change in the color. And I think it's because the cataract's black. Remember, when you have a white cataract and you put trypan blue, blue on a white background really highlights the dye, but blue on black, you can hardly see the dye. And so that was one of the first things I realized. I was like, wow, I knew I put good dye, but I can't see it even very well because the cataract is black. So black on blue, black on navy blue is not so helpful. And so, I'm buckling up, kind of mentally preparing myself that this is going to be a doozy of a cataract. I've already prepped my staff that this is going to be a really tough case. You can imagine from the patient's perspective that he has essentially no vision, just light perception vision. This is a capsule fornix hydrodissection technique. I place a cannula under the rexus edge contra-incisionally, point the tip down. Obviously, there's no wave. I'm tilting the lens because I want to make sure I'm going to really separate the lens from the bag. And you can see it's really spinning quite easily. So there is complete disengagement of the bag from the lens. And I go ahead to the dense setting because there's no sense in doing this in the standard setting. And of course, you can see there's no milk. There's no soft lens material. There's no soft epinucleus or cortex. It's just all rock. It's all dense. So I skipped trying to remove the surface epinuclear material because there is none. So I go ahead and start sculpting. And as you can see, it's really, really dense. I'm trying not to put any stress on the zonules. Everything's going, exactly the way you would expect it to go in a case like this. I'm just sculpting and sculpting. And in this case, and that's one of the learning points, when you're dealing with a dense cataract, you really do need to depend upon the phaco machine. Thankfully, we have very good phaco technology. And so in these kind of cases, it really makes very little sense to rely on mechanical forces and techniques when you have to really cut the lens with the phaco machine. And so that is really the first learning point, and you're going to see what I mean by that as the case progresses. So go ahead and spin the lens 180 degrees, and I'm sculpting some more. I go ahead and turn the bevel down, and I switch to quadrant removal mode. And I'm going to try to perform the terminal chop technique here. You can see this lens, again, the capsule is very difficult to see on the black background. I try to get underneath the rexus edge and perform the terminal chop. Fracture from the equatorial side. Taking my time. Infusion is on. I try to fracture the lens. You can see immediately there's no cushion. There is no surrounding soft material. And as I fracture, I'm able to fracture a little bit, but I'm not able to get a through and through chop here. I got some fracturing here. Just a little bit. Go ahead and turn it the other way. Just taking my time. Want to get underneath that side, that's right. Trying to perform another terminal chop maneuver on the other side. What I'm doing is I'm having trouble visualizing the anterior capsule, and that's my problem here. It's such a dense cataract. And now because what's happening is I'm just stuck. The lens piece, once I placed that phaco tip deep, it was like grabbing onto the sharp edges of the lens. And so I'm really having a little bit of trouble trying to just get the lens to orient the way I want to perform another terminal chop maneuver. Here we go now. We're going to try to perform another terminal chop maneuver. You can see I'm just really trying to be careful, making sure I'm getting under the rexus edge here, making sure I get a good chop. And you see that the pieces just don't want to come apart. I'm just really struggling to get these pieces bisected completely. Again, there's no soft material, there's no cushion, there's no epinucleus, there's no cortex. It's just all dense material. I have cracked from the top, but I have not achieved a through and through chop. And this is essentially, again, that posterior plate phenomenon where I didn't get complete chop. As I place the chopper around the rexus edge here, I notice something. The lens is tilting as I'm trying to lift it up. But as I lift it up, I'm able to see the rexus edge. Trying to get around the lens pieces. But look what's happening. The lens is tilting vertically. Now, why would that happen? The lens should not tilt vertically within the capsular bag, especially with such a monster-sized cataract. And this is when I realized that I have an anterior capsule tear right there. An anterior capsule tear, contraincisional. So again, even though I tried my best to make sure I got a through and through chop, you can see here, this is when I notice that there is an anterior capsule tear, which is also propagated into a posterior capsule tear. So what do? I take the chopper out, I push more viscoelastic in, and then I take the phaco tip out. I take a moment to breathe, pause, try to orient myself, figure out what's going on. So then when I stop, I go ahead and put another dispersive viscoelastic cannula, get underneath the lens material, pushing viscoelastic underneath the lens material to create a cushion and a barrier between the lens and the vitreous. I'm also using the cannula to lift the lens pieces up. And this is when I decide, okay, I'm going to convert to an M6. Go ahead and abandon the phaco incision, close the incision with a tendonylon suture, and then using scissors and forceps, go ahead and perform a peritomy. And then I'm going back to my basic fundamentals on my M6 techniques. I did post another video on M6 previously to that, and I'm going to share with you the things that I remember and learned again, relearned for this case, and that is this. You need to put a traction suture on the other side. You have to put a traction suture on for two reasons. One, it allows you better exposure to your dissection for your scleral frown incision. Before, on that other video, if you look in the past, I really struggled to get good exposure, and that's because I didn't put a traction suture. You have to have good cautery as well, as you can see here. And now this is my frown incision. You want to be confident. Make your frown incision starting a little bit back on the sclera. And then when you get to the central portion, you want to be at least, a couple, 3 millimeters away from the limbus. And you have to be deep. On that other case, I wasn't deep enough and it was superficial. Luckily, I got away with it. But on this case, I made the intention to make sure I am deep enough for my scleral tunnel. And you'll see with this case, this is a much stronger scleral tunnel in contrast to the previous one. So once I establish the depth, I start to place the crescent blade into the groove, and then I start to do the wiggle maneuver. And you can see here, I'm at pretty good depth. You can see here that I'm not so deep that I'm going to puncture too early, but I'm also not too superficial that the roof of the scleral tunnel will start to fall apart. And this is looking really good. I'm doing the wiggle maneuver. My only critique here is I should not be grabbing the roof of the incision. And I know this, but in the heat of the moment, you're just trying to get through the case. And I should not be holding the incision like I am here. And why is that? Because as you grab, you might rip off pieces of the tissue, and you don't want to do that. That roof of the scleral tunnel is supposed to provide support as you try to close the eye. Of course, this is not going to be like I did on my mission trip. I'm not going to try to make a self-sealing incision. I'm just trying to get through this case and get this lens piece out. This descending rock Cataracta Nigra pieces. You saw I swept side to side with this crescent blade. And then this is another cool tip. You want to push some viscoelastic in there to create a little bit of space. And that's because you don't want to accidentally cut a new tunnel as you're stabbing through. And you can see here, as I pushed the viscoelastic, a bubble went into the anterior chamber, which tells me I was already in. So I go ahead and switch to the crescent blade and go ahead and widen the incision, going all the way around. So you want to have the external incision I'm going in with more dispersive viscoelastic to lift the pieces up. Luckily, they are still suspended just underneath the iris plane. They're not falling. And that is because they're still vitreous, cushioning me and protecting me from the lens pieces to descend. That's why you can't go to straight vitrectomy here. You have to have that vitreous to support you. Get those lens pieces up. And now I'm going to go with the lens loop. Lift the roof with the forceps. Get underneath that first piece. As I lift the roof, I push down on the posterior lip of the incision and the lens piece comes out. This other piece is a little bit bigger. Go ahead and lift the roof with the forceps, and as it starts to come out, I just tease it forward. You can see these pieces are huge, but on this last piece, I could tell there's some potentially vitreous attached to the lens piece. So I go ahead and cut it with a scissor before I remove that lens piece further away from the eye. And so that's the other tip, is obviously I know there's vitreous loss because there's posterior capsule rupture, and as I remove that lens piece, always be mindful of that vitreous. So again, when you're pulling the lens piece out, don't pull away too fast. Go ahead and start cutting with the scissor at the incision site. I use a Weck-Cel sponge and I perform some more Weck-Cel vitrectomy. Here I do a dry vitrectomy. You saw that I just go ahead and place the vitrector at the main incision to remove any vitreous at the edge there. And then I go ahead and do a bimanual anterior vitrectomy, and then we start closing the incision. And so here you'll see the difference with this case versus the other case. With the way I sutured, the knot was exposed and I had to bury the knot, which was not easy. And so you see here, I'm actually starting with my throw within the incision itself. And so when you start in the incision first, that means the knot is going to be inside the incision, which is much easier to rotate. So again, when I made my tenonylon sutures previously, the knot was on the surface, but now by starting the suturing through the incision, the knot will be within the incision. It's much easier to bury that knot. After I've placed my sutures, I go ahead and do some more vitrectomy, and then this is the closure of the conjunctiva in a mattress technique. And this is essentially the end of this case. And you're going to see here, obviously, I'm not going to put a lens in. And why am I not putting a lens in? Because I'm going to be performing the Yamane technique. And so I left the patient aphakic. Go ahead and close up the conjunctiva. This is some intracameral triamcinolone to look for any more vitreous. I don't really see any vitreous at the wound. Perform my bimanual anterior vitrectomy. Look at how black that cataract is. I'm telling you. I kept it on the field because as I'm doing the case, I'm just trying to, again, remind myself on how big this cataract was. And so I'm going to perform the Yamane technique later on this patient once the eye heals a little bit. Interestingly enough, this patient, after surgery, was so happy that he could see. He could see his family members. He can actually see things, and which is, rather humbling and surprising since I left him aphakic. Part of you feels like, gosh, I wish I could have put a lens in. But when you think about it, this patient's vision was so bad before, he was happy anyways, even while he was aphakic. In fact, he even said if he didn't have to have any more surgery, he'd still be very happy. Of course, we're not going to do that. We're going to go ahead and follow up with a Yamane technique, which I will post in a future video. But the point is, this patient had a rock cataract. The lens was descending. I quickly realized what was going on. And again, I put trypan blue. I'm always very careful when I perform my chop techniques. But clearly in this case, which it's true, the bag and the capsule is so thin in these dense cataracts. And I also believe when you're dealing with these dense cataracts and you try to exert a lot of cracking force, when you're trying to separate the lens pieces, that's all it takes to cause that anterior capsule to split. So the point is I was not able to fracture the lens. I had anterior capsule tear, posterior capsule tear. The lens pieces were falling. Before I came out with the Phaco, I didn't want the chamber to collapse and invite more vitreous. I pushed dispersive viscoelastic to tamponade the vitreous back. It also provides chamber stability. It gave me a moment to pause to figure out what's going on. I closed the main incision with a tenonylon suture. I go ahead and do a perotomy in my scleral frown incision. In the standard MSICS technique, I use a traction suture contra-incisionally to turn the eye away from me, so I have better exposure on my scleral tunnel. I also pushed some dispersive viscoelastic within the incision to create that space so that when I stab, I'm not creating another incision. I go ahead and wind the incision, make sure it's completely wide, and then with the lens loop, I was able to very easily take those lens pieces out. And then I close the incision, again, starting inside the incision with a tenonylon suture, which makes it much easier to bury. And so what's interesting, this patient came in post-op day 1, and the cornea was crystal clear. And I'm not exaggerating when I say that. The cornea was crystal clear. And so it begs the question, should I have tried to phaco this eye anyways, or should I have just go straight with the M6 from the get-go? And that's debatable. I'm not quite sure what the answer is to that. But, if I had to handle this case with Phaco, again, there are certain things that I've learned and certain things that I'm going to do differently. Number one, with Cataracta Nigra, unlike the regular cataracts, you want to sculpt as much as possible. You got to get a lot of that dense lens material out of there before you start chopping. Because as I did that single groove and I did the terminal chop, it was very clear that I had too much lens material. Again, I had still a strong posterior plate. And when I fractured it, it just was ineffective. And that's the start of all my troubles. I have very little epinuclear protection. I have no cortex. And it's just the dense lens and that very thin capsule. And obviously the capsule lost and the lens won and the lens started to descend. And so if I did this again, I would do like probably a divide and conquer technique, which you think, oh, that's going backwards. No, with this kind of lens, you have to leverage the power of the phaco machine. You have to sculpt, go deep as possible, and then crack. Why would I do that? Well, because it makes sense. With soft lenses, you don't want to crack because the lens cheese wires because it's so soft. This is the opposite extreme. This is a super dense lens. When you do the divide and conquer, it's going to work extremely well because the lens pieces are so dense. It's going to be very easy to crack these lens pieces. But the mistake is trying to crack too soon with these cases. And so again, I would have sculpted a bigger and deeper trough and done it with a divide and conquer, a cruciate style technique. And then once I got really deep, and I think it would have taken a lot of time to sculpt, get really deep, even go more peripheral. And again, standard divide and conquer, you don't have to go far peripheral. In this one, I would go more peripheral, cutting that lens pieces, again, leveraging the power of the phaco technology to cut the lens pieces, and then I would start to crack. And if I did that way, I probably would have had an intact bag. I would have been able to very much more easily start to remove the lens pieces. I wouldn't have had the posterior plate phenomenon. And I think as long as you used a bunch of viscoelastic, I might have still had a pretty clear cornea. But it's hard to argue when you do this technique with M6 and you use basically zero phaco energy on that step. The lens came out pretty easily and I had a crystal clear cornea post-op. This is case 1 of this patient. Obviously, I left the patient aphakic, and you will see a follow-up video on when I performed the Amati technique on this case. And the last thing I want to say is, every case needs to be a learning case. I've been doing thousands of cataract surgeries. I do a lot of complex cases, hypermature cataracts, dense lenses, white cataracts, lenses with weak zonules. But this Cataracta Nigra kicked my butt. And the most important thing is not to be prideful, not to be sad, but to learn from this case and say to myself, hey, if I see this case one more time, I'm going to be better prepared and therefore be able to serve my patients better in the future. So I hope this was helpful to you, and I thank you for your attention.